I guess I should start by saying that I derive no gains whatsoever from my discussion with you about this particular topic. And I'm hoping in discussing this particular compound product with you that you'll gain from this talk some useful appreciation of how the product works, how to dose it, how to recognize when there's some problems, how to actually avoid issues and problems with it, and to try to get a sense about its place in the clinical armamentarium. OSR was developed by researchers at the University of Kentucky. It reduces intracellular oxidative stress, which is really one of its major mechanisms of action. It does this by increasing levels of intracellular levels of glutathione. One of its really unique aspects is that it is a hydrophobic or fat-soluble compound. As such, it can enter the lipid compartments of the body, theoretically crossing lipid-rich membranes and accessing lipid-rich brain tissue. I want to point out the chemical formula of OSR. It starts off with a dicarboxylic acid ring with a cysteamine moiety attached to two of the carbon molecules on the ring. And for those of you who want to have a picture of how it can actually connect up with things called toxic metals, these sulfhydryl groups here actually can act like swing arms, and unlike unlike other compounds that can actually that contain sulfhydryl groups that can actually capture mercury and other toxic metals, the other compounds have the sulfhydryl groups in fixed position. This has the ability to swing arm and actually can wrap around and capture, theoretically capture heavy metals. As you can see, the chemical name, there's several chemical names, but one of the chemical names is called benzene bis-amido-bis-thiol. OSR is a potent scavenger of hydroxyl free radicals in lipophilic areas. Now, when oxygen is utilized in the body, one of the major free radicals produced, one of the most toxic free radicals, is the hydroxyl radical. And OSR has a unique ability to capture hydroxyl radicals and protect against oxidative stress that is caused by many toxins. When it combines with glutathione, it makes it a water-soluble or hydrophilic compound. And this is a diagram showing the OSR molecule right in the middle here, and the sulfhydryl bond connects it up to glutathione, and so it actually makes the end portions of the molecule water-soluble. But this portion remains hydrophobic, and so it is uniquely able to position itself in the membrane of a cell by being the hydrophobic area is projecting out from the membranes, and the lipophilic or hydrophobic part of the molecule lodged in the cell membrane itself. And the molecule will actually be charged with this configuration, very water soluble, and a pH of 7.4. Now, most available antioxidants that we have available to us in clinical practice are water-soluble because they carry ionic charges, such as DMPS, DMSA, glutathione, and selenium are all charged compounds and are rapidly cleared from the body. Therefore, they are not as efficient at removing hydroxyl radicals in fatty or hydrophobic environments or in intracellular structures such as mitochondria. OSR does complex with mercury, lead, cadmium, arsenic, and uranium. Matter of fact, to my knowledge, it's the only compound that actually can definitively capture uranium and facilitate its excretion from the body. It is also unique in that it is excreted through the bile because of its hydrophobic nature and eliminated from the body through the gastrointestinal tract. So it does not aggravate in kidney function like the other compounds that I talked with you about have the potential for doing. I want to emphasize, however, that chelation studies on animals and humans with this compound have not been performed yet. Now, in the laboratory studies with the OSR, rodents that were given doses of OSR per body weight at levels of 100 up to 5,000 times the doses that were recommended for humans showed no evidence of adverse reactions or toxicity. I'd mentioned that each molecule of OSR contains 2 molecules of cysteamine. Cysteamine is a derivative of the amino acid cysteine, which enhances the increase of intracellular glutathione. Now, my experience with OSR at my clinic, between July 7th and December 31st of 2008, we treated 261 patients, 38 of whom were children, and 223 were adults. Now, in a clinical setting, when you're in practice and you're doing patient-funded research, there's limitation in ability to be able to do all the tests you'd like to do. I could have certainly done a whole host of testing, ideally, on these patients before and after they had taken OSR, but I limited the test to the whole blood glutathione levels, and I will expound a bit on that. We did whole blood glutathione levels on 156 patients prior to starting the OSR. Repeat levels were obtained anywhere from 4 to 6 weeks after beginning the OSR. Now, the reference range was, for the whole blood glutathione at the lab I was using, was 568 to 1,511 micromoles per liter. And this is showing what the glutathione levels look like prior to starting OSR. And I just want to comment a bit about the outliers. This is a lady who had very low glutathione levels, and she's a lady who's 52 years old, an RN, who has been diagnosed with primary biliary sclerosis. And she also has been diagnosed with hepatitis C, and also on the chelation, EDTA DMSA chelation challenge test had lead levels of over 150 micrograms per gram of creatinine. And so she was very heavy metal toxic. Dave?
Any optimal range of the glutathione?
Well, higher the better. The higher the better. Now, this is showing the baseline glutathione levels just specifically on the 33 patients for whom we actually did the follow-up lab tests on them, and you can see the spread. Now, this is the effects of OSR on the glutathione levels, with the baseline levels being shown in the diagrams here, in the diamonds, and the follow-up levels above that in the pink squares. The average increase in glutathione levels was 9.2% in this population. Now, it may not sound like much, but when you increase your intracellular glutathione levels by 9%, that really does substantially increase the body's ability to detoxify. And this just is showing the same the changes in the range.
Question.
Yes.
Whole blood glutathione representing both serum and intracellular and midcellular?
That's correct. Whole blood glutathione represents both the intracellular and serum. Right. Now, 10 of the patients we did stool tests on before and after taking OSR, and in reflection on this, I would have delayed the time a little bit more, and of course gathered more data points. But again, remember, this is patient-funded study, and so I limit the number of testing I'm doing because I'm trying to get something that's going to be useful for the clinical practice in these patients. But this is anywhere collected the pre-test. The time between pre-testing and post-testing was ranged anywhere from 3 to 90 days. Now, there were 9 children in ages 2 through 10 and 1 adult that was 58 years of age. Interestingly, 5 of the out of the 10 tests showed an increase in stool toxic elements after the OSR, and 5 showed a decrease in the toxic elements after OSR. Now, the increase or the decrease is based upon what the majority of the elements measured in each test showed in the pre versus the post testing. Now, in 39 patients with multiple whole blood glutathione levels, 33 had 2 tests that were 4 to 6 weeks apart, and of those 39 patients in total, 26 showed an increase in value. An average increase was 219.4 micromoles per liter, and the maximum was 325. Now, 12 patients showed a drop in value after they'd been on OSR, and the average was drop was 224.6 micromoles, and the maximum was 278. Now, 6 patients had 3 tests, 4 to 6 weeks apart. 4 of those showed progressive increase in glutathione levels, and 2 of them showed an initial drop followed by an increase on the 3rd or subsequent determination. But, you know, of course, we are asking the question, why would it go down? And I, unfortunately, was not careful enough in my discussion with patients to make certain that they did not take Tylenol. You may not be aware of it, but Tylenol can really quite dramatically reduce glutathione levels. And it was an oversight on my part not to have mentioned that, because it could skew the test. But I know for a fact that most of my patients, I talked with them about not using Tylenol, and I suspect most didn't. But what we found is that glutathione, of course, is a significant antioxidant, and we know it is a detoxifier of heavy metals just in its own right. Individuals under greater oxidant stress or with a higher toxic metal burden require and utilize more glutathione to detoxify. And thereby they can actually eat up, if you will, the lower available glutathione until such a time as it can actually increase. OSR does not increase glutathione directly. What it does is it actually liberates, the theory is that it could liberate metals from the enzymes that are involved in either synthesizing or recycling glutathione. And that's how it increases. It has been my consistent observation. Now, you know, we've treated now over 300 people since we started with it, and I'm continuing to gather some data with it. But if a person has a drop in glutathione levels after we start OSR, and they're not on Tylenol, it pretty much to me tells me they've got a significant toxic metal burden, and it's going to take longer to clean them up. When metals are mobilized, the demand for glutathione could increase beyond the body's ability to produce it, which is what I just said. Theoretically, by continuing with the OSR, the body's ability to produce glutathione can eventually catch up, and the levels would rise on subsequent determinations. Every patient whose whole blood glutathione levels decreased had a documented level and a known exposure to the toxic metals.
John?
Yes?
Are you correlating these results with the presence of amalgam in the patient's mouth?
What was the question?
The question is if I'm correlating these with the presence of amalgam in the patient's mouth, and I'm not. And from what I have been able to determine, at least so far, is that the OSR does not partition into the saliva and does not erode the existing fillings. Of course, the outgassing continues, as we all know, and it's best to try to get out of the shower before you dry off. But I have been using it on patients with amalgam fillings.
Okay, well, I was thinking those whose values went down. Did you see any correlation?
No, I haven't, because I've seen a number of those who go down, they correlate in terms of that's an exposure. I said that if they have an exposure, a known exposure. With children, of course, it's vaccinations, and it's also maternal exposure from maternal amalgams, and with adults, it's the amalgams that they in their mouth, as well as, you know, sources such as fish. Certain over-the-counter drugs I mentioned about acetaminophen or Tylenol can dramatically affect glutathione levels. Taking such compounds may have been part of the reason why we saw drops, and I know it was in some individuals as I go back. Again, I'm not a person who designs clinical studies. My population that I'm dealing with is N equals 1 at any given time, my study population, and I'm really working trying to get people feeling better and hopefully gather a little useful information in the meantime that can be shared with some colleagues. There are over 200,000 cases of reported Tylenol toxicity are documented every year, with about 500 deaths due to Tylenol, greatly diminishing the glutathione levels in the liver, causing liver failure. For those of you who are not MDs, the emergency room procedure for treating a Tylenol overdose is actually inhaled N-acetylcysteine, which is, of course, one of the building blocks of glutathione. Glutathione is a tripeptide composed of glutamine, glycine, and cysteine. And cysteine is the rate-limiting nutrient in the body's synthesis of glutathione. Now, most participants initially started off with just a 100 milligram dose a day. After establishing tolerance, the dose for adults was titrated upward gradually to identify a positive response or an adverse response. We actually provided patients with what we call a trial size vial of OSR, which contained 10 to 12 doses. And if a patient's going to have an adverse reaction, they were going to have it almost always within that time frame. So they didn't have to spend a lot of money on a compound they couldn't use in case they did have adverse reactions, which I will discuss. The maximum dose we went up to with adults was 400 milligrams a day, but I'm quite confident you can go beyond that. Of course, I mentioned the animal studies where they were given doses up to 5,000 times the dose a human would take with no untoward effects. Although I rather suspect that the animals involved in the study were not particularly verbal in expressing any discomforts they may have had. The children's dose was kept at 100 to 200 milligrams a day based upon body weight, and like a 40-pound child would be dosed at 100 milligrams a day. Now the vial itself says, not for children under 4 years of age, and we know that it has been given to children who are younger than smaller than that, and with a proportionately lower dose. But some of my colleagues who are using OSR across the country, the MDs, are actually starting off with 400 milligrams, getting a positive response clinically, then dropping the dose. I prefer to come up from underneath. I think it makes more sense to identify issues and problems at the beginning before you start creating some potential mischief, which I will discuss. We tell people to take just one dose a day, whether it's 100 milligrams, 200, 300, or 400, just one dose a day. And they can be taken with or without food. It has a rather unpleasant sulfur taste, can be taken with nut butter on those individuals who don't like the taste of it. I've had some patients liken it unto what they would imagine the south end of a northbound skunk would smell like. I told them I've never really sampled that, but I don't think it is any. Bragging rights are not part of OSR's strength, that's for sure. It can be encapsulated, and I understand it will be available in capsules. For those patients who really don't want to mess with the powder, they can take the powder to a local compounding pharmacist, and they would be very willing, I'm sure, to put it in capsules for them. Don't mix it with water or anything water-based. It will not dissolve, absolutely will not dissolve. I discovered during the holidays that it dissolves very nicely with eggnog, but it's not available right this time of the year. The only significant allergic reaction that was reported was in my patient so far that we have heard about from anybody across the country. And his was an interesting story. What is not listed here, I guess it was mentioned here, was that he had traveled to Nigeria he had started taking OSR right after he got back from travel, a 2-week travel to Nigeria. And he developed he'd take the dose in the morning, and he'd feel really crummy the morning, and by late afternoon he's coming out of it, and he'd take another dose. He did it for like 8 days in a row, and he was taking 160 milligrams a day. Each day was getting worse, and then finally he ended up developing 104 fever, sweating, hypotension, vomiting, and diarrhea, flu-like symptoms, ended up in the hospital. Well, he just got back from Nigeria, so you can imagine the emergency room doctors and the attendings that he picked up some kind of bug. Well, it took him, they tested him up one side and down the other. They couldn't find parasite or anything with an infectious agent to explain that. And he got over it, goes home, takes another dose of OSR, ends up in the hospital again that night. So it was pretty clear that that his symptoms were caused by the OSR itself. Again, we'd have figured that out had he been paying more attention. And of course, he was very early on, and we're still learning how all this works. But it was clearly obvious within days of taking it that he's not doing well with it. Now, other intolerances to OSR that we've seen include diarrhea. I've seen it stop diarrhea with autistic children, interestingly. Constipation, I've seen it stop constipation in people who are constipated. So the pendulum can swing on either side of the midline with that. Nausea, flu-like aching symptoms, insomnia, irritability, hives, and not listed as also on the slide as rash. We've seen a couple patients who had rashes with it. So as with any compound, it is not a panacea, and there are some people who will not tolerate it and do well with it.
Do these, for instance, hives, they go away after?
Yes, in all cases, the symptoms went away with discontinuation of the compound.
Do you ramp up to develop more tolerance?
I'll get to that. Individual intolerances, most are untoward symptoms will occur within the first 10 days of use. It's estimated to occur in less than 10% of patients, and I'm quite clear it's quite a bit less than 10%. But do watch for an increase in thyroid hormone levels in patients taking thyroid replacement therapy. And we suspect what's going on there is that the thyroid function impairment is caused by heavy metals, and when those are low glutathione levels, and when that problem is reduced through the use of OSR, indigenous production of thyroid hormone kicks in, and the person can develop symptoms of hyperthyroidism, so do be alert to that when you're giving OSR. Patients with difficulty processing sulfur compounds are going to have problems with OSR, because OSR, as you saw in its chemical formula, is a sulfur-containing compound, and it's a sulfur that is actually makes it as effective as it is. There are single nucleotide polymorphisms, we call them SNPs, which are gene code errors in either gene code, base pair deletions, additions, or subtractions, and such as the CBS upregulation, which can be either heterozygous or homozygous, as can be the sulfite oxidase enzyme gene, the SUOX gene it's called. So individuals who have those individual inherited gene SNPs could very likely have problems with OSR. Now, the other piece that actually I'm pleased that we figured out at our clinic is that molybdenum plays a role in insufficiency or deficiency in molybdenum. Molybdenum is an essential factor in the function of the sulfite oxidase enzyme that assists in the conversion of sulfite to sulfate in the body. Adequate molybdenum enhances sulfite oxidase enzyme function, enhancing the sulfation pathways. And we have found that concomitant administration of molybdenum can reduce symptoms of intolerance to OSR, and I think it reduces the side effect profile by about 50%, the number of individuals who will have an adverse reaction to it. So if a person's not been taking a multimineral with adequate molybdenum, I put them on that for a couple weeks before even starting the OSR. Most of my patients, of course, I also get red blood cell element levels on them, and if they're low in molybdenum, I will supplement molybdenum before starting OSR. If they've been taking a multivitamin, a good quality multivitamin mineral preparation for years that contains adequate molybdenum, I'll go ahead and start the molybdenum and the OSR concomitantly. Impaired sulfite oxidation enzyme function can lead to difficulty tolerating sulfur-containing compounds and foods. Mercury, interestingly, binds molybdenum. Now, molybdenum is not easy molecule to absorb. There are 6 electrons in its outer orbit, and it's not easy for the body to naturally transport that across mucous membranes and into the bloodstream. And so when we dose molybdenum with adults, we'll use a dose of 1,000 micrograms once or twice a day, typically twice a day. And with children, it'll be a commensurately lower dose than that, of course, apportioned by weight. Now, conditions that can benefit from OSR are really those that are usually related to or caused by oxidative stress. And of course, oxidative stress is a contributing factor in almost all chronic illnesses, including things like osteoarthritis, rheumatoid arthritis, and neurodegenerative conditions, including regressive autism, Parkinson's disease, mild to moderate cognitive impairment, and in the dementia, including Alzheimer's. Now, some of my colleagues across the country who've been using OSR have reported some quite striking benefits in Parkinson's patients. I unfortunately have not seen that, but I've treated 4 Parkinson's patients, and I suspect they're individuals who have that SUOX gene SNP and have not been able to tolerate it. And I've been working with them trying to get them to take it, but they've had intolerances heretofore in all of them. I want to give you some case. Go ahead, Steve.
How can you tell if somebody has a SUOX problem?
Well, you can test it. There's gene testing that allows you to. There's several places that will test that.
Is that the one where you eat asparagus?
No, that's not. That's the Babe Ruth gene, we called it, because, you know, Babe Ruth made some comment about every time I eat asparagus, my, smells funny. Anyway, but that's a part. That is they have some trouble clearing the sulfur groups from the body. But I think most people, if they eat enough asparagus, their urine will smell like Babe Ruth urine. I never smelled Babe Ruth's urine either. I want to give you some case presentations that'll help illustrate some of the patients who have shown some benefit from OSR. Now, like with any doctor, you know, we don't present usually our worst cases, although I gave you the case of the fellow with the terrible reaction, but I think you need to know that that can happen and avert that. So if somebody starts OSR, they start feeling bad, stop, you know, and tell them to stop when you first prescribe it for them or recommend it for them. First is a 65-year-old white female presented to my office on 5/10/07 with severe recalcitrant insomnia, including difficulty initiating and maintaining sleep. And she was resistant to all of the pharmaceuticals that were tried before she got to see me, and she just was having a terrible time with sleep. Now, her past history was she had DCIS, ductal carcinoma in situ, and had undergone bilateral mastectomies. She had anxiety, nervousness, impaired balance, hypertension, hyperlipidemia, and she had a mouthful of 10 mercury amalgam fillings. Her amalgam fillings were removed by one of our biologic dentists in our group, and nutritional deficiencies were identified and treated. And we did neurotransmitter testing, and we restored balance to her neurotransmitters. And I did a DMSA challenge test on her, and it showed elevated lead. You know, the lead wasn't dramatically elevated. It was like 35. You know, it should be less than 5. And despite nutritional and pharmaceutical treatment, her insomnia persisted. The OSR was begun on her at 250 milligrams a day back in 7/7/08. You may say, well, didn't you say that you started 100 milligrams a day? Well, I wasn't back then. And there was confusion because different batches of OSR would have different concentrations. And some of you may who've dealt with this have noticed that initially it was very fluffy and airy, and then the next batches that came out were more concentrated, and it had to do with the speed with which the compound was dried and the temperature it was dried at that determined crystal size and affected weight-volume relations. So we were still playing with this back in July. And so anyway, I started off with a dose of her that was 250 milligrams a day. And her whole blood glutathione level started out at 620.4, which is at the very low end of reference range. And within a matter of a week or two, she reports, I'm feeling more focused and she's sleeping better. We did a whole blood glutathione level on her, was 712.8. And when the next batch came out, it was a smaller crystal size, and now we had new spoons in the vials. And there was these little bitty, itsy bitsy spoons, like measure 1/20th of a teaspoon, and they must have had time finding a spoon that size anyway. But anyways, we said, well, I mean, it sounds like maybe we're giving you too much, so we cut her back to 100 milligrams a day. She lost the benefit. Her white blood cell glutathione dropped down to 531.8. We increased her dose up to 200 milligrams a day. White cell glutathione came up to, our whole blood glutathione level came up to 652. Still no improvement. We got back to 250 milligrams a day. Benefits returned, and that test is still pending. But I thought it was an interesting case to show that there is a dose-response curve with OSR, that if you are under the dose you need to be on, you're not going to get the benefit. So you need to push it up a little bit higher until you can see a clinical response.
How much OSR is in those little spoons?
It depends on the current batch is 50 milligrams, the current batch that they have, and the batch before that I believe was 100 milligrams in a little spoon. Yes, sir?
We're trying to determine whether you have an adverse reaction to OSR, but it's kind of confusing that if you're detoxing, if it is pulling out heavy metals, sometimes you will feel worse before you feel better.
I think it's a good point about trying to determine whether you're having a detox reaction or whether it's an adverse reaction to OSR. I had a couple of autistic patients for whom that point was well driven home, that the mothers had read about OSR on the internet or whatever, and then they put the kid on OSR, and the kid got worse and worse, and they just plowed ahead through it, and about 2 weeks later the kids came out of it and just were fine afterwards. So it's, you have to judge these situations case by case.
So that when you're saying if you see you're having maybe an adverse reaction, you got to continue for a little bit longer before
Well, I would talk to them and find out, and I would look at the context of that situation with them too, and they're warned about it, that there's a problem. And if they need a little more time to get their molybdenum levels up a bit better, especially with these autistic children who are usually undernourished, they have very limited diets, they have messed up GI tracts, they're not absorbing well. Phil?
What role does hydration
Pardon?
play? What role does hydration play?
I don't know the answer to that. I imagine hydration affects everything at some point, but I haven't really assessed the hydration status with them. Most people I see seem to be adequately hydrated. The next case is a 69-year-old white female presented to me on 2/23/06 with dementia. Now, at the time I'd first seen her, her daughter had previously treated her with EDTA suppositories and had her amalgams removed by a biologic dentist prior to her very first visit, resulting in significant improvement in her cognitive status. A DMSA challenge test showed her mercury level at 5.2, lead at 4.1, and cadmium at 2.3. These are not elevated levels. And she was treated with DMSA. Orally, and the DMSA challenge test on 11/1/06 showed her mercury level came down to 1.1, lead went up to 22, and cadmium at 2.3. But of course, the DMSA EDTA challenge test is a more potent challenge test than DMSA all by itself, of course. I did a challenge test on her at 5/21/08. Mercury was 2.1, lead 27, cadmium 3.6. The whole blood glutathione level on 6/24/08, or baseline level, was 646.6 micromoles per liter. Despite the continued use of DMSA and occasional use of EDTA suppositories, her cognitive function continued to decline. OSR at 250 milligrams per day was started on 6/30/08. It's not 6/36. That month of June only had 30 days, I believe, 30 or something. Anyway, 30 days, half June, September. Anyway, I have to go through that rhyme every time to remember. But I'm sure it wasn't 36. Anyway, on follow-up with her 2 months later, on 8/28, her daughter reported she's doing real good, more like her old self, better than she's been in a long time. Her white blood glutathione, her whole blood glutathione at that time was up to 888.8, up from 646.6. So a nice change that correlated really with her clinical status. The third case I want to present is a 5-year-old white male who was diagnosed with autism at age 30 months. He's treated with many modalities over the next 30-month period, including repeated antifungals and antiviral therapies, specific carbohydrate diet, allergy elimination, oral chelation with waxing and waning symptoms. He was started on OSR on 7/1/08. And experienced increased aggressiveness, irritability, insomnia, and diarrhea. Now, this is before I figured out the molybdenum piece. Mother was one of these determined mothers, and she plowed through it, continued giving him this despite these symptoms. After 2 weeks, the molybdenum was added, and the patient's symptoms promptly abated. 4 months later, her parents report to me, he's doing extremely well, a typical boy in every way. He's really excelling in school and learning at a typical level. His diarrhea, bloating, irritability, and aggressiveness stopped. The development of complex language skills, including humor and increased ability to make friends and socialize, were all noticed as well in his behavior.
That's the description of an autistic child?
He was neurotypical after treatment with OSR, is my point. 5 years old. And I have quite a few of those cases in my practice, and it's very satisfying when you get them. Of course, it's the most satisfying thing I do. It doesn't get better than that. Other symptoms improved with autistic children that taking OSR include improved listening skills, increased in reading skills and attention span, improved vocabulary, greater initiation of language, asking for what they want, more interactive with their family and their peers, improved eye contact and sleep, decrease in loose stools, decreased stimming, such as the flapping and the jumping and the spinning they do, and more observant of their surroundings. It's always interesting to me when these kids wake up and they go from no speech, and when they start talking, it's not mama and dada. They're talking in paragraphs. I mean, they've been processing all the stuff they hear in their environment, and when you get the neurons to fire, it's an explosion. That truly is a thrill to see. The fourth case is a 6-year-old black male who developed regressive autism after his MMR vaccinations at 12 months. He promptly stopped babbling, lost all of his speech, and developed 4 to 5 foul-smelling loose stools per day. At 15 months, he stopped responding to his name. Hearing his hearing test, of course, was normal. That's the first thing I always check. My hearing is off. He was given the flu vaccine at 5 months, and a second one at 6 months. I don't know why they give him that. Diagnosed with ASD, at autistic spectrum disorder, at 35 months, and poor compliance with the gluten. There was poor compliance with the gluten-free, casein-free diet. He was given a second MMR and the third flu vaccination at 42 months. Now you may ask, well, why did that mother do that? This mother was a surgeon. And she even asked her pediatrician, she said, I'm a little worried about doing this. Should I really give this child this vaccination? Oh, it's no problem. And even a physician couldn't resist the pressure that's put upon them.
Line leading the line.
It's incredible, really. Anyways, the treatment we initiated was methyl B12 injections, calcium EDTA intravenously, and he was given, I didn't initiate that, and DMPS IV was given to him by another physician before they saw me, and his lead level increased up to what excreted through the urine was 29, and mercury was 8.5. I did some labs on him, including showing IgG, IgE positive food allergies. Now, IgE food allergies, if they show up, you're really in trouble, because food allergies are not mediated by immune globulin E. And his porphyrin profile was also positive. On examination, he was an intermittently calm, interrupted by violent screaming, constantly moving, just drove everybody in the room nuts that he was with, and had no eye contact at all. He was treated with antifungals, probiotics, administered nutrients to correct documented deficiencies, and he was put on 100 milligrams of OSR a day. No response was noted in the first 3 months. The OSR was increased to 200 milligrams per day after that period of time. Within 1 month of increasing his dose, there was an increase in receptive language. Following instructions, sleeping well, much calmer, 1 to 2 foreign stools per day, talking more, asking for help, reading at school. Whole blood glutathione levels documented, and the 3 readings went from 418 to 484 up to 586. Again, this case demonstrates that you got to get the dose right. You know, if we'd kept him at 100 milligrams a day, I don't think he'd have responded. You needed to push the dose to see what you'd see. The last case is a.
Before you go on, there was methylcobalamin in one of the slides.
Right.
Do you have anything that you're going to say at any point about methyl versus hydroxycobalamin?
No, because my talk's about OSR. But I can address that first time. The last case is a 4-year-old white male with a history of regressive autism following his 18-month vaccinations. The 13-month vaccines, interestingly, caused a rash diagnosed by his primary care physician as measles. Well, I'm quite sure it wasn't measles. Seizures occurred 6 days after the 18-month battery of vaccinations were administered. His speech plateaued since then, and he had further regression over the ensuing few months. His lab showed an increase in the pre-coproporphyrin, 5-coproporphyrin, the pre-coproporphyrin europorphyrin, and the coproporphyrin europorphyrin ratios. These have to do with the porphyrin test that identify specific toxic influences on some of the enzymes involved in porphyrin synthesis. His hair analysis showed elevated aluminum, antimony, and arsenic. We did a ELISA test on him. It showed sensitivity to nickel. He had elevated ASO titer and anti-DNase B, which put him in the category of PANDAS. You may have heard of the acronym PANDAS, Pediatric Autoimmune Neuropsychiatric Disorders Associated with Streptococcal Disease. Boom, take a breath. His exam showed he was a very cute, curly-haired boy with good eye contact. He was flapping, stimming, jumping, unable to sit still, completely nonverbal. And on his exam, he just had some tinea corporis, which is a fungal infection on the skin. His diagnosis were regressive autism, PANDAS, I mentioned, which is an autoimmune reaction caused by strep that can actually affect brain function as well, mercury toxicity, nickel sensitivity, and yeast enteritis. He was treated with OSR, 100 milligrams a day, and we put him on prune juice. Now, that's the other point I want to mention. When you take OSR, make sure you're pooping, because it's excreted through the bowel, and if the bowels are not moving, the mercury and the other toxins that are delivered to the bowel will be absorbed through the enterohepatic circulation, and you'll end up back where you started from, if not worse, because now you've redistributed it. His response to 100 milligrams a day was improved verbal skills. He was singing, more attentive, seeking out his parents. He had improved eye contact. He was playing on his jungle gym, snuggling. He was affectionate. He had improved sleep and much more interactive with his peers. In summary, the OSR, I'd like to just say, give you a bit of a summary. The OSR is a potent oral hydrophobic antioxidant that can be helpful in a number of clinical conditions of diverse age groups. As with any agent, adverse effects can occur. Supplementation with molybdenum can reduce adverse reactions. It is safe to administer in humans, but is best used, in my opinion, under medical supervision. Generally, laboratory measurements of whole blood glutathione roughly correlate with clinical improvement, but exceptions do exist. And more human studies are needed to document the ability of OSR to facilitate the excretion of toxic metals through the gastrointestinal tract. And that's my talk. Thank you very much. Is there a time for a question or two? Go ahead.
How soon after starting OSR should you monitor the thyroid?
I don't necessarily monitor the thyroid in individuals. I warn people of symptoms of too much thyroid. The jitteriness, nervousness, feeling like they've had too much coffee to drink. And if they start developing those symptoms, I would be more alert to it. If a patient's been really stable for a long time on it, I have seen only a couple patients in whom the hyperthyroid symptoms actually started to come on. But I've been told by several colleagues that can happen, so you do need to be alert to that.
And common things happen coincidentally with common things.
Right. Yes, sir.
When you see these positive results starting to happen in your patients, then what is the long-term or chronic usage of the OSR?
I think it's completely safe to take long-term, and I just don't see any adverse, other than the things we've learned about it so far, is that it's, is what I've shown you. And in long term, once a person has established tolerance to the OSR, I haven't seen a hiccup with it whatsoever. I think so. I intend to. In the back. There are really no studies that have been done at all on this compound. I believe I'm giving the first talk to my knowledge in the country about the effects of OSR on humans. There's been a lot of laboratory work that's done with it that has unequivocally established its safety. But again, as I mentioned earlier, the participants in the animal studies have been very quiet about their complaints that they've had. And my rats and the rats in my experiments have not been quiet. Yes, sir.
Is this distributed to the physicians and dentists, which distribute to the patients, or the patients getting this script? How does that happen?
I am not really familiar with whatever mechanisms are available. I know you can procure this as a patient go online, and it can be found and it can be obtained. Again, I provide it out of my office to patients, and I tell them I give them all of the stumbling blocks, and I tell them these are things to look for and how we're going to avoid trouble with you. Above all, do no harm we should be sticking.
Do you suggest dentists not be providing this to patients?
I think it should be done under medical supervision, but if you are going to recommend it for patients, please be aware of these things so you don't cause mischief. This is an important compound that needs to be protected, in my opinion, so we don't hit a stumbling block that could cause some problems with its regulatory authorities having to do with the management of the product. So that's one of the main reasons why I wanted to give this talk, so people are more mindful of that. Yes, sir.
The market is an antioxidant, isn't it?
It is. I'm not sure, even though it is marketed as an agent that what is said about OSR is that it reduces oxidative stress, and I think I've proven that pretty well with humans, and it's been well proven in animal studies. Yes, sir.
Well, the last thing I heard was that it was going to be available this month in capsules from the manufacturer on a website, and you had to provide evidence of licensure.
Right. I believe the intention is to have it marketed only through health professionals, but I'm not that knowledgeable about all the other things. I know some doctors are actually selling it directly to the public off their websites. I'm aware of that, and that worries me a bit. Yes, sir.
Yeah, I appreciate the molybdenum today. Also, a rate limiting step is cysteine, you said. So N-acetylcysteine versus cysteine. I'm thinking cysteine in eggs. N-acetylcysteine is a weak T letter, so I kind of want to know opinions. Maybe we're getting the drop initially on the glutathione because we don't have the building block.
Well, that certainly could be the case. I think this is the man who can answer that more effectively than
The
I.
sulfur-rich foods are the cysteine-rich foods. There are 5 of them: garlic, onions, ginger, brassica sprouts, and eggs. Agree?
Yes.
You don't need DNA studies.
No.
That's a separate discussion. What I'm saying is start with biology, then go on. The biology are the 5 sulfur-rich foods, 1 or more of which in the diet is beneficial and will give you plenty of cysteine in the reduced and active unoxidized form.
And cysteine in itself it will actually capture heavy metals itself, and that's Mother Nature's way of facilitating the excretion.
I personally had a side effect from NAC. It acted like a repeat layer and made me worse.
One of the other points I wanted to make is that OSR could very likely be helpful for people who are intolerant of wine. And there's a lot of patients that I've encountered who just cannot tolerate wine, and it's because of the intolerance of the sulfites in the wine. And by putting these people on, excuse me, on molybdenum, thank you very much. A little fluoridated water should help that, right? By putting patients on molybdenum, I think you could actually get some people drinking wine again. It'd be good for the wine industry. Phil.
Any comment about MSG and OSR? Is it gloomy?
Not that I'm aware of.
Two points about that. The sodium salt and glutamic acid is not the cause of MSG syndrome. MSG syndrome is caused by hypersensitivity to the yeast fermentation edits that Monsanto allows and by GRAS standards are permitted in the food. It's not the sodium salt and glutamic acid. If you were hypersensitive to that, you wouldn't be alive. If you're alive, you can't be hypersensitive to sodium salt and glutamic acid.
Here's the website. It is ctiscience.com.
ctiscience.com is the website for the supplier, right? Yeah. Any other comments? Sir.
I was just taking one spoonful, but I was mixing it in water and swirling it around the water and trying to drink it.
Well, it sticks to the side of the glass. Put it in your mouth and then swish it down with water is fine, but I wouldn't recommend putting it in water. Get some eggnog. Yes, sir.
What about the inability of autistic children to process glutathione, as was documented by and are you showing elevated or increased glutathione in the autistic children as well?
Well, in the kids, the cases I showed you, yes, I am. It's just like, yeah, absolutely. They have impaired glutathione synthesis, I think, and they have impaired glutathione regeneration.
And impaired redox in general.
Impaired redox in general. They can't detoxify properly.
Everything else gets better.
Right. Yes, sir.
Just a comment outside your lecture a little bit. You know, the ADA since come out and said that glucometronol was not responsible for autism. Any opinion on that?
Yeah. Kind of like when back in the 1950s when doctors were doing commercials extolling the virtues of cigarettes. Kind of like that. Yeah. That's my comment. This is taped, right?